Good afternoon. I'm Dr. Viditi Bari, Index Department of Physiotherapy and Paramedical Sciences. Today's my topic is clubfoot, torticollis, and ciliage. Introduction. Clubfoot is also known as CTEV, which means congenital talus equinovarus, congenital present at birth, talus Latin word for ankle and foot. Equino heel is elevated, whereas foot is turned inward. Incidence is about 1 in 1000 live birth. It is developmental deformation. A normally developing foot turns into a club foot during second trimester of pregnancy, rarely detected with USG before 16th week. Pathological anatomy. CTV is a complex deformity with 4 clinical components. 1. Hindfoot equinus. 2nd. Hindfoot varus. 3rd. Mid-forefoot adductus. 4. Cavus. Clinical pathological anatomy of the clubfoot. Clubfoot is also known as CTEV, which stands for congenital, meaning present at birth, talus, derived from the Latin from ankle and foot, equino, indicating the heel is elevated, and varus, indicating the foot is turned inward. CTEV is a complex deformity with 4 clinical components: hindfoot equinus, hindfoot varus, mid-forefoot adductus. The deformity has the following features. The deformity has the following features: equinus, severe tibio-talar and talocalcaneal plantar flexion, adductus, medial talar neck incline, medial displacement of navicular and cuboid, calcaneus adducted, distal calcaneus articulating surface adducted, forefoot adducted in relation to hindfoot. Whereas adducted plantar flex and inverted calcaneus, cavus, plantar flex, first metatarsal. The deformity has the following features: equinus, severe tibio-talar and talocalcaneal at plantar flexion. Adductus, medial talar neck incline, medial displacements of navicular and cuboid calcaneus adducted. Distal calcaneus articulating surface adducted, forefoot adducted in relation to hindfoot. Cavus, plantar flex, first metatarsal, whereas adducted plantar flex and inverted calcaneus. Congenital clubfoot in newborn posterior view, inversion, plantar flexion, and internal rotation of calcaneus and cavus deformity with transverse plantar crease. In clubfoot, ligaments of posterior and medial aspects of ankle and tarsal joints are very thick and taut. Foot in equinus, navicular and calcaneus in adduction and inversion. The size of leg muscle correlate inversely with severity of deformity. There is excessive pull of tibialis posterior abducted by gastrosoleus and long toe flexors. These muscles are shorter than normal foot. In distal end of gastrosoleus, there is an increase of connective tissue rich in collagen, which tend to spread into tendoachilic and deep fascia. Classification. Classification in two ways: relation to cause of deformity, relation to treatment stage. First, relation to cause of deformity: idiopathic clubfoot, secondary clubfoot, postural clubfoot, metatarsus adductus. Relation to treatment stage: untreated clubfoot, treated clubfoot, resistant clubfoot, recurrent clubfoot, neglected clubfoot, complex clubfoot. Classifying the clubfoot deformity according to etiology. Child present with an apparent clubfoot deformity, the foot is assessed using the Pirani score. Child scores in birth, the hind and the mid foot Categories. The child is given a general physical assessment. Parent asked it if they have noticed any other problems. Is divided into two. The physical assessment to normal and no other abnormalities are noted. Second, some abnormalities are noted during the physical exam. Idiopathic clubfoot and secondary clubfoot. This is connected to child has symptoms indicated of a neurological condition, example spina bifida. Child has symptoms indicating of the syndromic condition, example arthrogryposis. Neuropathic clubfoot and secondary clubfoot. Pirani score, a reliable method for assessing amount of deformity in clubfoot formulated by Dr. Safik Pirani. A child's total score is between 0 to 6. Six signs are assessed and each is scored 0, 0.5 and 1 depending on severity. Total score of 0, no deformity. Total score of 6, severe deformity. Total score comprised of hindfoot contractures score between 0 to 3, posterior crease, empty heel, rigid equinus. Midfoot contractures score between 0 to 3, first medial crease, second lateral head of talus, third curved lateral border. Score summary. Radiographic evaluation. In a non-ambulatory child, standard radiographs include anterior, posterior and stress dorsiflexion, lateral radiographs of both feet. Api and lateral standing radiograph may be obtained for older child. Important angles to consider in evaluation of clubfoot are talocalcaneal angle on AP view and talocalcaneal angle on lateral view and talus first metatarsal angle. In clubfoot on AP view, talocalcaneal angle is progressively decreased with increase in heel varus. On lateral view, talocalcaneous angle is progressively decreased with severity of deformity to an angle of 0 degree. Tibiocalcaneal angle in a normal foot is 10 to 40 degree on stress lateral view. In clubfoot, this angle is generally negative, indicating equinus of calcaneus in relation to tibia. Talus first metatarsal angle measures forefoot adduction. In clubfoot, it is negative, indicating adduction of forefoot. Treatment. Non-operative treatment. Operative treatment. First, non-operative treatment. Most widely accepted techniques in described by Ignacio consist of weekly serial manipulation and casting during first week of life. Tibiocalcaneal angle in a normal foot is 10 to 40 degree on stress lateral view. In clubfoot, this angle is generally negative, indicating equinus of calcaneus in relation to tibia. Talus first metatarsal angle measures forefoot adduction. In clubfoot, it is negative, indicating adduction of forefoot. Consecutive methods of casting. First consists of two phases. Second, treatment phase. Third, maintenance phase. Treatment phase should begin as early as possible, optimal within first week of life. Gently manipulation casting done weekly. The order of correction by serial manipulation and casting should be as follows. First, correction of cavus, correction of adduction, correction of heel varus, correction of hindfoot equinus. Each cast hold foot in corrected position, following it to reshape gradually. Generally, 5 to 6 casts required for correction. Correction of cavus. First cast applied by extend first metatarsal and supinate forefoot. This elevates the first ray and puts the forefoot in proper alignment with hindfoot. Cast should be applied in two stages. First, a short leg cast of below knee and then extend till above knee when plaster sets. Long leg casts are essential to maintain a strong external rotation force of foot beneath the talus to allow stretching of medial structures and to prevent cast slippage. Correction of abduction and varus. The whole foot is abducted under talus. Thumb should be on the head of talus. The navicular moves away from medial malleolus and covers head of talus. The foot should never be corrected and heel should not be touched. Do not dorsiflex until you have reached 60 to 70 degree of abduction. Correctional equinus. When heel is in valgus, talar head is covered and the foot is in at least 60-degree abduction, equinus can be corrected by dorsiflexing foot. When tendon is tight, this is facilitated by percutaneous tenotomy of tenotomy should occur in around 90% of cases. Tenotomy. Timing of tenotomy. Pirani score indicates MFCS is 1 or less. Score for LHT is 0. Heel is in valgus. Foot is in abduction. Techniques of percutaneous acyclic tenotomy from medial to lateral, not proximally or peroneal artery, laser Stephanus vein and sural nerve to lateral edge of tendon. Timing of the tenotomy. Forced with the tenotomy as soon as the Pirani score indicating the MFCS is 1 or 0 less. The score for the lateral head of the talus is 0. It is covered by the navicular. The heel is valgus. The foot is abduction. Maintenance phase. When final cast is removed, infant is placed in a brace that maintains foot in its corrected position. This brace is foot abduction brace. It consists of shoe mounted to a bar in a position of 70 degree of external rotation and 15 degree of dorsiflexion. The distance between shoes is set at about 1 inch wider than width of infant's shoulder. This brace is worn 23 hours each day for first 3 months after casting and then while sleeping for 2 to 3 years. Without proper bracing, recurrence will occur in 90% of cases. Complication of casting, pressure ulcer, skin allergy, swelling, cast sleep, circulation problem, rocker bottom foot, muscle atrophy. Operative treatment. Surgery in clubfoot is indicated for deformities that do not respond to conservative treatment by serial manipulation and casting. In planning surgical correction, it is essential to recognize the mechanics and pathologic contractures preventing reduction. General principles for any one stage extensile clubfoot release includes release of tourniquets at the completion of procedure, obtaining hemostasis by electro careful subcutaneous and skin closures with foot in plantar flexion. Foot can replace this in a fully corrected position 2 weeks after surgery at first post-operative cast change. The following 3 types of contractures are seen: posterior capsule, acyclic tendon, posterior talofibular and calcaneofibular ligament, medial deltoid and spring ligament, talonavicular capsule, posterior tibial tendon, tendon of the FDL and FHL, subtalar, anterior interosseous ligament, bifurcate ligament. Extensive release include the posterolateral ligament complex, most often in required for severe deformity. The procedure is described by Mackey. MCK takes consideration into three-dimensional deformity of subtalar joint and allow correction of IR deformity of calcaneus and release of contractures of posterolateral and posteromedial foot. A modified MCK procedure through a transverse circumferential clinicate incision is preferred techniques for initial operative management of most clubfoot. Transverse clinician incision. This incision provides exposures of subtalar joint and is useful in patients with the severe IR deformity of calcaneus. Problem of this incision is tension on sutures line. To avoid this, foot can be placed in plantar flexion in immediate post-operative cast and then in dorsiflexion when wound has healed at 2 weeks. Extensile posterior-medial and posterolateral release by modified MCK. When equinus and varus deformity coexist, both must be overcome either separately or at same time. Posterior release alone will not correct hindfoot equinus because anterior end of calcaneus is locked beneath talus. Both ends of calcaneus and navicular must be freed so that anterior end moves outward and upward, with navicular as posterior tuberosity of calcaneus moves downward. This is achieved by modified Mackey procedure, which includes posteriorly acyclic tendon lengthening by Z-plasty, medially by releasing posterior tibial tendon, superficially deltoid ligament from calcaneus, capsules of talonavicular joint, and spring ligament. The deep deltoid ligament which insert into talus must be preserved. If this is divided, a platform deformity, flatfoot deformity with tilting of talus may develop. The deformity can now reduce by replacing navicular in front of head of talus. Anterior end of calcaneus moves laterally and inward while its posterior end moves downward and away from ankle joint. Talonavicular joint is transfixed with K-wire. Achilles tendon is repaired with interrupted sutures. Post-operative care, a long leg cast is applied with foot is plantar flexion. At 2-week cast is changed and foot is placed in corrected position. At 6-week cast is changed again and pins are removed. All casts are discontinued at 10 to 12 weeks after surgery. Achilles tendon lengthening and posterior capsulotomy. When there is residual hindfoot equinus in children 6 to 12-month-old who have obtained adequate correction of forefoot adduction and hindfoot varus, this is corrected by Achilles tendon lengthening and posterior capsulotomy of ankle and subtalar joint. Achilles tendon lengthening C techniques. In case of dynamic metatarsus adductus caused by overpull of anterior tibial tendon in older children who have had correction of clubfoot, in these cases, treatment of choice is either as a split transfer or as a transfer of intertendon to middle cuneiform resistant clubfoot. Treatment of residual or resistant clubfoot in an older child is most difficult problems in pediatric orthopedics. Residual forefoot deformity should be determined to be either dynamic with a flexible forefoot or rigid. The amount or inversion of calcaneus and dorsiflexion and plantar flexion of ankle joint should be noted. Any prior surgical procedure causing significant scarring around foot or loss of motion should be noted. Standing AP and lateral radiographs taken to assess anatomical measurement. All possible causes of persistent deformity like underlying neuropathy, abnormal growth of bones, or muscle imbalance should be investigated. The basic surgical correction of resistance clubfoot include soft tissue release, bone osteotomies. This procedure done based on age of child, severity of deformity, pathological process involved. In general, children 2 to 3-year-old may be candidates for modified MCK procedure if previous soft tissue release caused stiffness, osteonecrosis, talus should undergo osteotomies. Common components of resistance clubfoot deformities include first, adduction or supination, both of forefoot, a short medial column or long lateral column of the foot, IR and virus of calcaneus and equinus. Correction of forefoot with residual reduction or supination or both by multiple metatarsal osteotomies or by combined medial cuneiform and lateral cuboid osteotomies. In hindfoot heel virus, a long lateral column of foot of or a short medial column. Children younger than 2 or 3 years who had no previous surgery, corrected by extensive subtalar relief. Children 3 to 10 years who have residual soft tissue and bony deformities need combined procedures. Post-symptomatic ankle valgus, percutaneous malleolar epiphysiodesis using a 4 to 4.5 mm cortical screw has been recommended. Isolated heel virus with mild supination of forefoot, dire osteotomy with lateral closing wedge osteotomy of calcaneus done. Osteotomy of the calcaneus for persistent varus deformity of the heel. Dyer reported osteotomy of the calcaneus for relapsed clubfoot using an opening wedge osteotomy medially to increase the length and height of the calcaneus. The osteotomy is held open by a wedge of bone taken from the tibia. A modification of this technique is the laterally based closing wedge osteotomy of the calcaneus. Hindfoot deformity includes heel varus and residual IR of calcaneus with a long lateral column of foot, corrected long lateral column of foot by a closing wedge osteotomy of lateral aspects of calcaneus or by clubfoot cuboid enucleation. Complication includes Z foot or cave foot deformity, medial release with osteotomy of the distal calcaneus. An alternative to calcaneocuboid orthodesis is laterally closing wedge osteotomy of the calcaneus as described by this procedure may prevent the long-term stiffness of the hindfoot seen in the Dilvenion's procedure. Residual heel equinus in younger child corrected by Achilles tendon, lengthening at posterior ankle and subtalar capsulotomies. In older children, a, a lambrinoid orthodesis done. Residual midfoot deformity, talonavicular orthodesis done. If all three deformities present in a child older than 10 years, triple orthodesis performed. Rigid cavus or cavovarus deformity, a stepwise correction of the deformity with closing wedge osteotomy of first metatarsal, open wedge osteotomy of the medial cuneiform, closed wedge osteotomy of cuboid and second, third metatarsal, sliding osteotomy of calcaneus plantar fasciotomy, and peroneus brevis transfer, triple orthodontist talectomy. These two procedures are generally are salvage operation for uncorrected clubfoot in old and adolescent. Triple orthodontist corrected deformity foot by a lateral closing wedge osteotomy through subtalar and metatarsal joint. Talectomy performed for severe untreated clubfoot, previously treated clubfoot that is uncorrectable by any other procedures, neuromuscular clubfoot. Introduction. Next topic, torticollis. Introduction. Derived from the Latin tortus, twisted, plus collis, neck or collar. Torticollis is a symptom related to turning or bending of the neck. Introduction. Many different causes are possible in newborn. Torticollis usually result from injury during labor and delivery or the infant's position in the uterus. Less often it is caused by birth defect. In older children, torticollis may result from injuries to the neck muscle, common infections, or other causes. Torticollis refer to a symptoms rather than a distinct disease process. It can be caused by a wide variety of conditions. Over 80 causes have been described, which range from relatively simple, self-limited to life-threatening, may be congenital or acquired, occur more frequently in children than in adults. The right side is affected in 75% of patients. What does it look like? Abnormal twisting of the neck usually. Child's head is tipped toward one side with the chin pointed in the other direction. Painful spasms of the neck muscle may occur. Other symptoms may be present depending on the cause. For example, there may be a tender lymph node if the cause is infection. Normal and torticollis. See. Causes of torticollis. Congenital muscular torticollis and acquired torticollis. Congenital muscular torticollis. CMT refers to muscular disorder causing torticollis at birth or shortly after due to unilateral shortening of the sternocleidomastoid muscle. More common in males and on the right side. The affected muscle develop fibrotic changes which can be associated with a mass or without a mass. Congenital muscular torticollis. Presenting is usually during the first 4 weeks of life with torticollis and or non-tender neck mass to though to be caused by intrauterine and perinatal events. Risk factors for CMT include overcrowding environments, firstborn, oligohydramnios, breech presentation, and difficult delivery. Congenital muscular torticollis. Ultrasound sound is the imaging modality of choice for initial investigation. There is diffuse or focal enlargement of the sternocleidomastoid muscle. Focal mass is usually hypoechoic and homogeneous. The mass usually resolves within the first year of life with conservative treatment. The condition is treated with physical therapies such as stretching or release, tightness, strengthening exercises to improve muscular balance, and handling to stimulate symmetry. A collar is sometimes applied. About 5 to 10% of cases fail to respond to stretching and require surgical release of the muscle. Second, acquired torticollis. Acquired torticollis is the most common etiologies. First, self-limiting. Second, trauma. Third, infection. Four, inflammatory condition. Five, central nervous system tumors or lesion. For self-timing, a self-limiting, spontaneously occurring form of torticollis with one or more painful neck muscles is by far the most common. Stiff neck and will pass spontaneously in 1 to 4 weeks. Usually the sternocleidomastoid muscle or the trapezius muscle is involved. Colds or unusual postures are implicated. However, in many cases, no clear cause is found. Second, trauma. Occipital condyle fractures and facet dislocation may present with torticollis. Atlantoaxial rotatory fixation of C2, spontaneous spinal epidural hematoma is a rare disorder which might manifest with painful torticollis followed by weakness and sensory loss and is mostly common at the cervicothoracic level. Subarachnoid hemorrhage. Trauma. CT is the modality of choice in most trauma cases. MRI is indicated in case of concern for ligamentous injury or when there is a neurologic deficit. Infection and inflammation. Head and neck and spinal column infection may cause torticollis either by muscular or ligamentous irritation or from direct spinal disease. Infectious and inflammatory causes of torticollis. CNS related, meningitis, head and neck related, upper respiratory infection, otitis media, mastoiditis, cervical adenitis, retropharyngeal abscess. Third, spine related, vertebral osteotomies and or discides is epidural abscess, rheumatoid arthritis. Infection. Lateral neck X-ray radiograph will show increased soft tissue thickness anterior to the C-spine in retropharyngeal abscess. US may show superficial lymphadenitis and abscess. CT is used to visualize the deep neck space and for pre-surgical planning. MRI is useful in spinal column infections due to its increased sensitivity and its ability to show soft tissue and epidural extension. Infectious causes of torticollis, mastoiditis, basalts, abscess. Fourth, tumors. Tumors of the CNS, spine and neck may cause torticollis. CNS tumors are usually in the posterior fossa or C-spine. The common presentation of C tumor is pain due to dural irritation. Posterior fossa tumor, cerebellar tumor may also have sign of increased intracranial pressure. In any case of insidious development of torticollis, the possibility of a tumor should be considered. MRI is the imaging modality of choice. Other causes: the use of certain drugs such as antipsychotic, antiemetic, neuroleptic class, and phenothiazine can cause torticollis. Treatment of torticollis depends on the cause. For newborn with torticollis, gentle motion of the head and neck is recommended to stretch the muscle. Often, a physical therapist is involved to avoid injury. This should be done only in as recommended by a doctor. For older children with torticollis related to infection or inflammation, treatment may include antibiotics for the specific infection, rest, anti-inflammatory medications such as ibuprofen, passive motion to keep the muscle from gentle stiff, surgery is if indicated. If the causes is related to trauma, when sleeping position, treatments may include muscle relaxants, William, generic name diazepam, and passive motion, a soft collar or brace to support the neck. Differential diagnosis list to acquire torticollis. Conclusion: torticollis is a clinical sign that might signify an underlying disorder. In newborn infant with CMT, ultrasound is preferred and often diagnostic. In older children, CT is used to diagnose traumatic insult, neck infection, and vertebral anomalies. MRI used to diagnose inflammatory and infectious spinal disorder, and in case in which CNS or neck malignancy is suspected, developmental dysphagia of CDH. It is a spectrum of intracapsular displacements of femoral head from its normal relationship with acetabulum before, during, or just after birth, present in different form in different stages. This syndrome in newborn consists of instability of hip such that femoral head can be partially or fully be displaced from the acetabulum and be reducible on examination. The term DDH encompasses syndrome ranging from dysplasia and subluxation to frank dislocation, dysplasia, deficient development of acetabulum, obliquity and loss of concavity of acetabulum with intact Shenton's line, subluxation displacement with some contact remaining between articular surface, head widened, teardrop head distance, center edge angle greater than 20 degree, break in Shenton's line, dislocation, complete displacements of joint with no contact between original articular surface. Teratological dislocation occur with other disorder like myelodysplasia, arthrogryposis, are dissolved at birth, have limited range of motion, not reducible. Incidence 1.4 to 1000 in newborn, 40% after first week, 10% after the 1 month, 10 by 10,000 born with subluxation or dysplasia, 2.3 by 100 have clinical findings, 8 by 100 have ultrasound abnormalities. Respect: female, male, 6:1. First born, family history 6% one affected child, 12% one affected parent, 36% one child plus one parent. Hydroamnios. Breech delivery is in 35 breech deliveries increase in frank breech, negative Americans, swaddling cultures, associated condition, torticollis 15 to 20%, metatarsal adductus 1.5 to 10%, oligohydramnios. Etiology. Etiology is multifactorial and influenced by genetic, hormonal, and ecological influences. Congenital teratological example associated with AMC, syndromic with Larson, Freeman, Sheldon syndrome, dystrophic dysplasia, neuromuscular associated with spasticity, poliomyelomyosine, inheritance, autosomal dominant trait with incomplete penetrance, predisposing factor, ligamental laxity. Newborns respond to metatarsal relaxin hormone, increased ratio of collagen 3 to collagen 1, parental positioning mechanical force, increase in breech delivery, more in frank breech risk 20%, as left sacro-anterior position is more common than right, left hip is at higher risk of dislocation, more in firstborn, more in oligohydramnios, postnatal positioning, waddling, racial predilection, decrease in blacks and Asians, increase in whites and Native Americans. Development. Both femoral head and acetabulum develop from the same piece of mesenchyme of primitive limb, but a left appears to separate them at 7 to 8 weeks. Hip joint is developed at 11th week. At birth, acetabulum is composed of cartilage with a thin rim of fibrocartilage around it. The structure of the acetabulum is determined by the femoral head, which is placed inside it. Center for ossification of femoral head appears between 4th and 7th month of postnatal life and grow until physial closure. Acetabulum fuses at around 18 years. Any deviation from normal embryogenesis leads to malformation. Example PEF, PFFD, development in DDH. At birth, the affected hip spontaneously slides in and out of the acetabulum. Posterior superior wall of acetabulum loses its sharp, contoured neolimbs in form. This sliding in and out produce a clunk. Some hips spontaneously reduce and undergo normal development, while others develop secondary changes. Secondary barriers production develop thickened limbus, which then hypertrophies and inverts, presenting as a diaphragm between femoral head and acetabulum. Pulvinar, paired of fatty tissue in depth of acetabulum, ligamentum teres elongates and thicken, transverse acetabular ligament hypertrophy, hourglass constriction of hip capsule, contracted iliopsoas cause further capsule narrowing. If stable reduction is achieved at early stage till at about 8 years, the structure remodel and normal development inserts changes in hip that remain dislocated. Acetabular roof gradually become more oblique, cavity flatten, medial wall thicken. An adult present as high reading dislocation and case with fully dislocated hip may remain free from generative changes. An adult with untreated subluxated hip, instability persists and degenerative changes appears including subchondral sclerosis, osteophyte formation, loss of articular cartilage. Clinical feature: gait abnormality, adductor large, waddling gait, limb length inequality, glassy sign, asymmetric gluteal folds, increased lumbar lordosis, scoliosis, limited abduction, telescopy of hip, high plus GT, autonomy sign, Barlow sign, and classic sign. Classic sign, Barlow manual and autonomy manual. Investigation: X-ray, ultrasound, CT, MRI, orthographies, gold standard. On X-ray, Hyggen line, Parkin line, Shenton's line, acetabular index, center edge angle of Wilberg, acetabular depth of width normally 38%, widened acetabular teardrop, von Rosen's view, with hip abducted, internally rotated and extended. In normal hip, medial base of the full femoral metaphysis lies in lower inner quadrant, 27° in newborn, 20° around 2 years, maximum 30°. Ultrasonography, static non-stress techniques, graph, dynamic stress technique, dynamic standard minimum examination, DSME, graph technique, morphological assessment, release on anatomic lines, baseline line of ilium as it intersect bony and cartilaginous portion of acetabulum, inclination line along the margin of cartilaginous acetabulum, acetabular roof line along the bony roof, angle between roof and baseline, alpha greater than 60%. Evaluate bony acetabulum angle between inclination and baseline, beta 55° evaluates cartilaginous acetabulum. Graph classification. Orthography, gold standard, using sodium ditrizonate 76% in 1:1 dilution through median subadductor approach, finding blunting of rose thorn sign, outline the limbus, hard glass constriction of capsule, medial pooling of dye 7 mm, filling defects in acetabular floor, filling defect in acetabular hypertrophied ligamentum teres. Management 0 to 6 months. First watch in Hortolani, positive public hardness in 100 to 110° inflection till 6 to 8 weeks before weaning is started. Follow VT using USG success 70 to 90%. 6 to 18 months. Close reduction and immobilization in hip spica may require adductor tenotomy before adductor reduction. Position flexion greater than 90°, abduction 30 to 40°, within safe zone of Ramsey, internal rotation 10 to 15°. Hyperflexion may cause femoral nerve palsy and inferior dislocation. Excessive abduction, internal rotation may cause ABN. Duration 6 weeks, 6 months. Check after every 6 weeks and pre-apply cast in case of instability. Reduction considered stable if abduction can be done till 20, from maximum abduction and extension beyond 90 without redislocation. Indication for open reduction, felt clause reduction, persistent subluxation, soft tissue interposition, unstable reduction. 18 months to 3 years, open reduction may require osteotomy. Beyond 3 years, open reduction, osteotomy, acetabular reconstruction. Thank you.